Greetings, my name is Rama Limani. My colleagues and I will be presenting our case, Group 9, Week 7, Najal Qahtani, Lulu Rumi, Yara Al-Habib and Farah Halis. Patient's history, she is a 16 years old female. Her chief complaint, pain from her left cheek. History of chief complaint, 2 weeks. Habits, none. Past medical history, patient had an attack of syncope during previous dental visit. No medical history was provided, therefore it could be due to severe anxiety. Family medical history, patient's father has been operated multiple times for a cyst of jaws. Drug history, none. Allergies, none. Under extraoral examination, facial swelling on the left side of the mandible was detected. Moving on to the X-ray description, radiolucency was detected on the posterior left side of the mandible and associated with the developing third molar attached to the cemento-enamel junction of this developing third molar. Also, CBCT scan confirmed lingual perforation on the left mandibular ramus.
Hello everyone, my name is Yara Al-Habib and now I will talk about the radiographic interpretation. The type of radiographic projection is extraoral radiograph, panoramic view, and CT scan. Location, site, and number of lesions. It's located on the mandibular body and ramus area. On left side, posterior region, molar region, unilocular and solitary. Size and shape. The size is vary from 2 cm to 3 cm and the shape is oval shape. Regarding the extent, it extended from the body of the mandible to the ramus area, and it's grow in an anterior-posterior direction within the medullary cavity of the bone with minimal buccolingual expansion. About the periphery and borders, the periphery is a well-defined cortex with a smooth corticated borders. Internal structure predominantly radiolucent. Effect of lesion on surrounding structures. It's grow and infiltrate along the internal aspect of the jaw through the cancellous bone along the body of the mandible and causing minimal buccolingual expansion. Displacement of lower border of the mandible. Displacement of tooth number 3-8 and inferior displacement of inferior alveolar canal.
Hello everyone, my name is Farah Halis and I'm going to talk about the differential diagnosis. So according to the case that is given, we suspected 4 differential diagnoses. So the first differential diagnosis is dentagerous cyst. So according to the age occurred during second and third decade, and according to the gender, greater and male. And according to the site, commonly associated with the third molar and maxillary canine, which are common impacted tooth. According to the clinical feature, symptoms are absent associated with cortical bone expansion. Radiographic feature, well-defined cortical border attached to CAJ. The second is odontogenic keratocyst. Age, any age, but peak and second and third decade. Site, mandibular molar and the ramus region. Clinical feature, symptoms are absent unless secondary infected. Radiographic feature, defined radiolucent with scalloped margin. The third one is ameloblastoma. Age, any age, but peaks in fourth and fifth decade. So about the gender, males and females are equal. Site, posterior region of mandible. Clinical feature, local expansion of the jaw, tipping or loosening of the teeth. Radiographic feature, unilocular or multilocular, well-defined sclerotic border, honeycomb or soap bubbles. So the fourth one and the last one is radicular cyst. So according to the age in third to sixth decade, and the gender and male more than female, sites incisor and canine region in the maxilla, clinical feature asymptomatic, radiographic feature radiolucent and sometimes with dystrophic calcification and long-standing cyst, cause expansion or cortical borders.
Hello everyone, my name is Lulu. Today I will talk about the investigation of odontogenic keratocyst. In the biopsy step, a fine needle aspirational biopsy with decompression is performed. Aspiration contains a creamy cheesy-like material. The biopsy report of most cases came back as orthokeratinized. In the histopathology, The basal cell layer is thin squamous lining. It is straight and regular without retroridges. The retroridges are finger-like projections, but they do not appear here. The basal cells are palisading. They resemble elongated nuclei and they are arranged one to another and corrugated layer of parakeratin on the surface. Squamous cell epithelium is thin, and according to the literature, it should have 6 to 8 cells. The presence of parakeratosis is another important morphological sign for differential diagnosis. Parakeratosis means that we have epignotic nuclei retained in the superficial layer of keratinocytes. Inflammation, like secondary infection, is usually sparse, but it may obscure the diagnostic histological feature, making it hard to diagnose. The key features of OKC that it resembles 1/10 of all cysts of the jaw. It appears in second or third decades of life, and there may be a male predilection. It can be unilocular or multilocular. It forms intraosseous, most frequently form in the posterior alveolar ridge or the angle of the mandible, and it can be seen in the maxilla. May grow around the unerupted tooth. Frequently, it reoccurs after inoculation. The aspiration is a cheesy-like creamy material. Definitive diagnosis only can be made by histopathology, although the clinical and radiographic features may allow accurate preoperative diagnosis.
Assalamu alaikum. My name is Najla. I'm going to talk about the case analysis. For the clinical feature, age, gender, site, periphery, and shape, and the internal structure of the lesion, it's all referred for odontogenic keratocyst. For the treatment, we will do wide local surgical excision to prevent the recurrence by marsupialization or inoculation. For inoculation, this technique involves complete removal of the cystic sac and healing of the wound by primary initiation. This is the most satisfactory method of treatment of a cyst, and it is indicated for all cases where cysts are involved, whose wall removed without damaging adjacent teeth and other anatomic structure. For the marsupialization, this method is usually employed for the removal of large cysts. Entail opening of the surgical window at an appropriate site above the lesion in order to create the surgical window. Initially, a circular incision is made, which includes the mucoperiosteum, the underlying perforated bone, and the respective wall of the cystic sac. After the procedure, the contents of the cyst are evacuated and interrupted sutures are placed around the periphery of the cyst, suturing the mucoperiosteum and the cystic wall together. Afterward, the cystic cavity is irrigated with saline solution and packed with iodoform gauze, which is removed a week later together with the suture. During the period, the wound margin will have healed, establishing permanent communication. Irrigation of cystic cavity is prepared several times daily, keeping it clean from food debris and potential infection. Syndrome associated with odontogenic keratocyst. The odontogenic keratocyst is known for its high recurrent rate, aggressive behavior, and it's usually associated with nevoid basal cell carcinoma syndrome. The other name for the syndrome is Gorlin-Gold syndrome, or associated with Marfan syndrome, or Noonan syndrome.
Thank you for listening. رام اليماني، نجل القحطاني، لولو الرومي، يارا الحبيب، فرح الهليس.